Welcome back to the Dermcast studio. It's Rob Casquejo, and we are in Boston, Massachusetts. Today, I'm with Dr. Joslyn Kirby from Penn State Health, and welcome, Dr. Kirby.
Thanks, Rob.
So I'm a huge fan of yours. You've been a long-time supporter and friend of SDPA. I've seen you lecture multiple times, and I absolutely enjoy. You're well loved by the SDPA, so I just want you to know that, number one. But we're going to talk today about Hidradenitis Suppurativa. Horrible disease. Or as they'd say back in Pennsylvania, horrible. But you're a heavy hitter in this subject. Heavily involved in research and publications on the HS Foundation. So give us a second. Tell us about your accolades, and we'll go from there.
Well, I can't really talk about myself, but I would love to talk about the HS Foundation and just all the stuff that's happening around HS. I think for many of us, we feel like HS is so motivating because these patients suffer so much. And I don't know, I guess speaking of my own motivation, I always root for the underdog. If a game is on, I'm going to root for the team that's behind.
Yeah, well, I'm a Detroit sports fan, so I'm always rooting for underdogs. So
we always love the story of like coming from behind. And I think that certainly our patients sometimes feel a little bit left behind in the delays of diagnosis and the struggles to get information about their disease and struggling to get good control over the condition. And, certainly their story motivates us, but I also think sometimes as providers, we are in this to help people get better. And sometimes we are frustrated because we aren't seeing the improvement. So in doing a lot of HS, I really tried to focus my talk today on what are those things that have helped me get more success with my patients and help both of us feel like we're winning rather than underdogs.
That's very evident in the material, and I think that's the important thing is we know what the data shows in terms of delay of diagnosis. How many providers they see before they get diagnosed, actually how many years can happen, how young they are when it first really appears clinically. So it's a problem. And therapeutics, there's some things happening. We've got some things, we got new things coming. So let's just jump right into that, therapeutics. So first of all, let me ask you about something I know you like to do that maybe a lot of folks don't know about, Resorcinol. Can you talk about that?
I really like Resorcinol, and I think it was born out of my frustration with topical clindamycin. Topical clindamycin is talked about all the time as a first-line agent to help with the condition, but I had so many people coming in saying, it just doesn't do anything for me. And I didn't have a lot of other topicals that I could use. So there were a couple studies done in Europe that showed the benefit of this topical Resorcinol. Now, how it's doing what it's doing, we don't completely understand, but it's doing something. And I think putting another just little bit of a caution on it, which is it's not going to work for really big, deep things. But for more superficial papules and nodules, this is something that people can take to work. They can take on vacation and feel like they can use when they need a rescue. So it's kind of a brown paste. They put it on twice a day. The studies show that a typical flare might last for 7 to 9 days. This takes it down to 3. The pain with a flare, people started around a 7, brought it down to about 1 to 2. So pretty powerful information for something that's just a topical. The other challenge with Resorcinol is it can be hard to get, and it has to be compounded. There aren't a lot of compounding pharmacies that have it, but once you find that compounding pharmacy network in your area, just sending the prescriptions over. I usually prescribe about 30 grams, and it lasts people for 3 to 6 months.
Okay, great. And how long is the therapy typically in terms of length of therapy?
So you can use it one of two ways. One is just as a rescue. So when you have a flare that needs it, you can put it on. And so again, it's going to shorten that course of a flare and therefore the need for the Resorcinol down to a few days. But there was also a study that looked at more persistent lesions, so not things that were just flaring up, but that had been there chronically. People put on the Resorcinol twice a day for about 30 days. It helped with those more stubborn, but also, again, more slightly superficial lesions.
Okay, great. That's perfect. So, and when we go into systemic treatments for hidradenitis suppurativa, it's one of those situations where there's kind of this, there's a variety of things that can be used, and there's sort of this ambiguity into what works best and so forth.
Yeah.
So let's talk about that a little bit. We know that. I know that you're doing research currently. You've published research in particularly for IL-17. So why don't we talk about the frontier of using IL-17 for hidradenitis suppurativa?
Absolutely. So I've learned so much by being a site in these clinical trials. The first thing it made me reflect on is when I'm recruiting in those trials, who are we recruiting? So it's moderate to severe HS, but people have to have 5 or more inflammatory nodules. So this is less about the therapeutic and more feedback for me when I first started doing this on why was I waiting so long? Because if I could recruit somebody into a clinical trial with just 5 or 6 or 10 inflammatory nodules and abscesses, upon reflection, I was feeling like I was waiting longer. I was requiring a higher burden of disease down in clinic. And so I've just really re-level set, if that's a thing, and saying, I don't need you to suffer with a higher burden of disease. If you are suffering, if your pain is not under control, if your quality of life is impacted to a moderate to severe level, then I need to open up my mind and consider this as an indication for a biologic. And from the trials, I think I've also gotten more optimistic and seeing whether it's the interleukin-17s or other types of agents that are being studied for HS, things are working. So it's really just a message to everyone out there who is working on HS and sometimes frustrated, whether you're a provider or a patient, there is a lot of good stuff that is happening and that is coming. And I think the IL-17s, to your point, Rob, are going to be the first thing that gets a new indication. So we've begged, borrowed, and stealed every biologic from psoriasis off-label, but pretty soon we're going to have new things that are on label. If I had to guess, I think secukinumab is going to come next. I think the agent to come after that is going to be bimekizumab. That's a 17A and F inhibitor. And then really the playing field is wide open after that. Lots of different agents with different mechanisms.
And that's very encouraging to hear. So can you summarize what you saw in clinical trial with secukinumab?
Yeah, with secukinumab, we saw a pretty decent overall response. So in a population, when we look at hundreds or thousands of people who are given this medicine, is it working? The answer is yes. When I've used it off-label, I saw in some of my patients who had failed TNF inhibitors, and so I was using secukinumab off-label for that failure. I've had a few people with very severe HS, often ulcerating HS, who did amazingly on secukinumab. So I think that it's a good agent. It plays a role even for people who had TNF alpha failures. And I think the whole field, like all of us in HS, as the therapeutic choices get more numerous, I think we'd really benefit from having a little bit of a test that could help us just take the guesswork out of therapies. And I think we're going to see that in psoriasis. And if I had to guess, I think in HS. And it's just going to help us and our patients make a more informed choice. But we'll have a lot more choices pretty soon.
That's great. Yeah, with those kinds of things, people have been talking about sort of genetic profiling of diseases for some time. So hopefully that comes to direct us better.
Yeah.
But it helps to have some therapies to choose from. So this is great that the frontier is opening up. That's exciting. So we'll look for it. As I understand, the trials look good, and it's just basically, any day now for FDA approval.
Absolutely.
All right, fantastic. So another question, because a lot of us probably delve into isotretinoin sometimes out of pure desperation with hidradenitis suppurativa. So tell us what the course of treatment is like with isotretinoin as management for hidradenitis suppurativa.
Yeah, and I agree with you. I think that we use the tools we have in our toolbox for a number of different conditions, whether it was psoriasis or acne or eczema, in order to make a difference in HS. But the therapies don't always translate quite the same. And I think that is especially the case with oral retinoids like isotretinoin. Isotretinoin is an amazing drug for acne. And when people are on it for their HS and maybe their acne, everything gets better. But what's amazing about isotretinoin in acne is you stop the drug and the acne stays under control for the vast majority of patients. That is not the case in HS. Right. The HS goes right back to where it was. It's not necessarily worse, but you didn't get that sustained response that I think we're all hoping for. Right. So your choice is leave people on isotretinoin and take on the hassles of the REMS program for both you and the patient. And then also I think the data for acitretin, when we looked in the North American clinical practice guidelines, is actually slightly better for acitretin, and you don't have the REMS program that goes into that. So I guess my answer to your question is, if you're using isotretinoin for HS, just know that it's going to require a chronic course, and just that you and the patient are ready for that. And the same goes for acitretin. When you're on it, it's going to be usually as an adjunct. If it's a solo therapy, it's usually for, I would say, milder stage 2 or stage 1. And it seems like the folks who might respond the best have a little more HS maybe on the upper chest, the shoulders, the back. They have concomitant acne. So there's a slightly different phenotype that might be a little more amenable to oral retinoids.
Right, we see that every now and then, that sort of more diffuse hidradenitis that looks like and it's
Overlaps
probably
with
been-
acne, yeah.
and it probably has been managed as nodular acne for a really long time.
Yeah.
That one's a curveball.
Yep.
Because you sort of miss it sometimes. Then they start showing up in the armpits, and you're like, wait a second.
Right.
Yeah, that's
Well,
usually-
and that is a great point in that there's an opportunity to look for HS in the patient with acne, for the patient with Down syndrome who comes in, for the patient who's dissecting scalp cellulitis. So there are some kind of things that if you hear it in the office, go looking for HS.
Right. So fantastic. So these are things that all of these are things that have been used, and some things, the concepts like biologics, they're coming. They've been around. We've had TNF inhibitors, but there's some sort of outside the box things like weight loss drugs. Talk about what you know, what you can tell us about those therapeutics.
Yeah, so I stumbled across some good success in my own clinic with Metformin, and it came out of using spironolactone in women with HS and having some people have a partial improvement, and they were tolerating it really well, and I just didn't want to give up on a therapy that was doing something and not causing trouble. So what could we add to it to maybe add a little more improvement? And there was some data in acne for Metformin. So these were teenagers, normal, healthy, not having comorbidities that would have required Metformin. And they gave it to them for their acne, and they had a decrease in their inflammatory load. So I started adding it to spironolactone, and I had a number of women who were completely clear and controlled on the combination of spironolactone and Metformin. And there's a little bit of data in the clinical practice guidelines for HS, but I think with the development of some of the GLP-1 agonists, so some of the drug names are Ozempic and Mounjaro and some others, and also with some data showing that when we control people's concomitant diabetes, it helps with inflammatory conditions. So that's a really long-winded way of saying that when we leverage this part of the immune system that seems to be responsive to insulin and insulin-like growth factor, that it's an opportunity in HS.
That's very interesting. And then but what I also hear from that is not really the weight loss that's helpful. It's more the metabolic things that are.
It might be both.
Yeah.
So
Okay.
when people are on one of these GLP-1 agonists, which are injectables, if they have some weight loss, that might help. And there's a little bit of data to suggest that with a decrease in weight, people can have a reduction in HS. But, and I really want to emphasize this, it's not a guarantee. I think it's really important to know that the data is not universally recommending that weight loss has to happen in order to get HS improvement. And that it is very easy for us to say in a visit, if you lost some weight, this might help with your HS. That's, I think, a really delicate topic, and again, easy to say and much harder to do, especially when somebody has difficulty with just their activities of daily living. Putting on pants, sitting in a chair, driving to work or to an appointment.
So I like to summarize the expectation part of disease management by telling people, well, in medicine, you never say never and you never say always.
Mm-hmm.
So it's an unfortunate part of the difficulty of managing this disease state. So speaking of management, we talked about some therapeutics, and I know that you're also a proponent for surgical intervention. And deroofing is something that's surgically widely accepted to treat this as an option for treatment. But we know the wounds that are created, they can be fairly big wounds and be very difficult for the patient, but with pretty good outcomes. But talk about how you manage those wounds. It may not necessarily be something that the average, derm provider that does surgery is doing. So what is that like? Talk about management of let's say, status post de-roofing.
Yeah, so I think the first thing that I realized was that a lot of these patients, the lesion I'm going to do a de-roofing or an excision on is usually a tunnel, which can drain. So that person has kind of already got some success, some ideas of what works for them for wound care. I don't have to always reinvent the wheel because they've figured out if I just put a panty liner in against my underwear, it helps protect that spot on my waistline. Or I figured out that I have a tighter shirt that I wear underneath my regular shirt and it helps hold a dressing against my underarm and avoid tape. So I think just talking to the person about what they're already doing and maybe leveraging that. If somebody doesn't have a routine that works for them, couple things you can use. Cheap, easy things that if you can't get stuff covered by insurance would be feminine hygiene products. They are relatively cheap, they're relatively easy to find, and they are made to hold liquid. So the nice thing is that they stick against clothing rather than against the person's skin. And so many times people with HS, they get more irritation from the tapes and adhesives. And of course, there's no tape that is both gentle and very secure. You have to pick one or the other. A silicone tape is going to be gentle on your skin, but not the most secure, whereas a fabric tape is usually going to be very secure, but also tear up the skin afterwards. So that's why I think we try and use clothing, or there are some products that you can get through insurance. And so I'm usually looking at the category of dressings called alginates, which are approved for everyday changes. And you want to document when you order the number of wounds, because insurance will cover one dressing for each wound. Okay. So keeping in mind what level of changes you think your patient might need, and then working backwards into the order.
Got it. And what about when you do dressings, are you using any kind of wound healing emollient, or is there something you prefer to do or use?
Yeah, great question. So honestly, these wounds heal great once you get the inflammation out of the way. So even though they are very often affecting skin that's in the genital area, the buttock area, the rate of infection is not higher than other things that we're doing surgery on that might be on the arm or on the leg or on the back. So I think that it's just important to say, if you can do a non-melanoma skin cancer surgery, if you can do a melanoma surgery, then you can absolutely take that practice and just turn it into an HS procedure, because the wound care afterward is going to be really similar. Just wash it once a day, put on Vaseline, find a bandage that works for that person, and pretty much the size and extent and techniques of the procedure itself are translatable.
So a lot more simple than you might think. Perhaps there's this perception that, oh my gosh, it's this going to be this crazy wound care afterwards. Maybe that's why they avoid the surgical options.
Yeah.
And I also heard in there that, it's just simple wound care, so there's typically no need for prophylaxis with antibiotics and so forth.
No, I have patients send me photos like every week or every 2 weeks afterwards. Yeah. And some of the time it's because I want to check them, but I also get so much joy from seeing that wound heal.
It is very satisfying. I've seen your photos that you have for your before and afters, and it's fantastic. So when do you see them back?
I usually see my patients, if we don't have maintenance therapy ironed out, then I'll see them every 4-ish months. But once people are on a good regimen, I'll see them every year.
And then specifically after a de-roofing?
I just follow them up with pictures.
Photos, okay.
Yeah.
Great. I imagine you're really busy, so you.
Well, so are the patients. So if they don't need to take time out of their day and drive over to my office.
That's great. So then, so scarring. Let's say not even in the context. Let's say in the context of after even excision or de-roofing, and even scarring with controlled disease on medication. So scarring in general after all of these. Is there anything you like to do for management? Do you keep treating maybe ILK, maybe silicone? Is there anything that you like to do in these situations?
Yeah, I think everything you mentioned is totally reasonable. And with HS, again, we're kind of borrowing from other conditions. There hasn't been as much research on HS scarring. To preface all of this with that, I think that we're focusing on finding the drugs that get the HS under control, and then we'll be able to focus on the recovery of the skin texture and appearance afterwards. But until we get that evidence, I think we're all borrowing things like topical retinoids, which have been shown in acne to help not only get the acne under control, but help with scarring. The silicone tape, the massage, intralesional Kenalog for more hypertrophic or keloidal type scars. So I think you can take all those practices you already have and just use them for HS. I tend to just talk with people about how we want to get the disease under good control before we start working on the scars, because otherwise we're kind of chasing our tails a little bit.
Got it. Well, that's fantastic. That's a really, so we covered a lot of things, and I think this is really useful for people who are currently managing or maybe just starting to learn to manage these conditions, because we covered things we know, we covered things that are coming, and we covered both medical and surgical options. It's fantastic. So let's end with this. I'm going to just bounce some stuff off of you, just random questions, probably unrelated, and you're going to give me your quick fire answers back, and
all right.
We'll see if
I'm ready.
People can get stuff. All right, okay, get your thinking cap on. So losing weight will improve my hidradenitis, true or false?
Partially true, partially false.
Okay. Then the quick explanation of that. What does the research suggest?
It suggests that for some people, their HS can improve, but will not be totally in remission with a change in weight.
Okay. If I am a smoker, my hidradenitis will be worse.
If you stop smoking, your HS may improve, but there is no guarantee.
I can do intralesional Kenalog indefinitely for HS.
I think that there's some situations where really you're between a rock and a hard place, and Kenalog is something you can do periodically to help keep people under control. But it's hard. It comes with side effects too. People have to stop everything and come to your office, and you're always chasing the episode. It's never that you're in front of it and stopping it from impacting the person in the first place.
And pregnancy will always make hidradenitis worse.
Not true.
Okay. All right. If I had to choose for a starting biologic in hidradenitis suppurativa, I'm going to choose secukinumab or adalimumab first.
So it depends on context. And I think part of it is what that person's insurance might cover and also what their comorbidities are. Because I think right now we have data for both drugs, and it's kind of similar in terms of their rates of high score achievement, which is that level of improvement that we use in HS right now. So it's kind of a question of, does somebody have a contraindication to a TNF-alpha inhibitor? And some of our patients are pretty young but have already had a malignancy, and we need to work around that. If they have ulcerative colitis or Crohn's disease, maybe we want to avoid a 17, and it might help, the TNF-alpha might help with their inflammatory bowel disease. So I think context is important.
Okay, great. Okay, last one. This is a big one. So if Dr. Kirby needs an energy boost, she prefers a Diet Mountain Dew or coffee?
Totally a Diet Mountain Dew. Yeah, I should be sponsored by Diet Mountain Dew, actually.
That's why I threw it out there. We'll see if we can tag Mountain Dew and see if we can't get you some sponsorship. Well, thanks so much for stopping by the studio. That was fantastic, and I very much enjoyed sitting and talking with you at this level. I've been watching you for years lecturing, and this is so cool for me to have you here in the studio. And thank you for supporting the SDPA for all these years and for this conference here in Boston this summer.
Absolutely. Thanks so much, Rob.
Come by anytime.
Thanks.
All right. Thanks for watching Dermcast TV with Dr. Joslyn Kirby, Rob Casquejo in Boston, Massachusetts.